So again, coming back to Bang.
Esteemed judges. So I'm going to be presenting my paper on clinical outcomes of Bent Ab Interno needle goniotomy in different stages of primary open-angle glaucoma. So very briefly, what is BANG? It is a minimally invasive glaucoma surgery which employs an ab interno approach to de-roof the Schlemm's canal so that a direct communication of the aqueous from the anterior chamber to the Schlemm's canal can be made, and it utilizes just a needle to do that. And it is a low-cost alternative to the more popular Cahook dual blade, whereas it is probably 1/500th in cost. So in the background is that BANG was first presented at American Glaucoma Society in 2019 by Arsham Shabani and Shute. It's their brainchild. As a cost-effective alternative to other TM-based procedures, they presented their paper in 27 eyes of 21 patients and saw that at the end of 6 months, there was a 20% reduction, whereas there was no reduction, significant reduction in the number of medications they could bring about. So very briefly, this is a procedure on BANG. So like any other mixed procedure, you make a temporal incision and use a good cohesive viscoelastic to deepen your anterior chamber and for better visualization. This is how the needle is fashioned. This is the needle needs to be bent little short of 90 degrees and then another slight bend at the tip. The surgical gonio prism is placed and the angle structures are visualized, and then the procedure is carried out. It can either be done from an out to in procedure or an in to out procedure, wherein the needle is hooked and then the horizontal part of the needle, which is bent, strips the trabecular meshwork about 90 to 120 degrees. So the published literature so far has been very limited. Most of these studies have also been published by the innovators themselves, and they have shown that there has been an IOP reduction of 20 to 30% over 6 months. An average AGM reduction of 1 was achieved. 73% of patients could be medication free at the end of 6 months. So the clinical questions that I wanted to answer was, do we achieve a significant reduction in IOP and number of medications in Indian eyes with BANG, and what is the role of BANG in the treatment of mild, moderate and severe glaucoma, and also the fact that is it safe? There is no published studies from India yet. So phaco alone, as we know, can bring about an IOP reduction only very mild to moderately. So this was a retrospective chart review of 30 eyes of 22 patients, 21 out of whom underwent phaco BANG. It was done by a single surgeon at a single center, and all glaucoma severity of all grades were taken, mild, moderate and severe, and the patients were followed up over 3 months post-operatively. The type of glaucomas that were included were POAGs and NTGs. Male-female ratio was 9:13. Average age of patients was 59 years. Average mean deviation on the basis of Humphrey visual fields was -8.71 and average CD ratio 0.74. So at the end of 3 months, we saw an IOP reduction of 18.43%. The pre-op IOP was 17, post-operative month 3 IOP was 13.87, and this reduction was statistically significant. The pre-op number of drops were 2.47. Post-operatively, there was, at the end of 3 months, there was a drop reduction of 0.67, which also was statistically significant, and almost half the number of patients had an IOP reduction of less than 25%. Next question is whether it is able to reduce IOP and AGMs throughout all severities of glaucoma. So on that basis, we found that mild and severe cases of glaucoma had a significant reduction in intraocular pressure, except the moderate category, which brought about an IOP reduction of only 9.05%. And as far as the AGM reduction was concerned, mild and moderate patients did well. They had a significant drop in the number of AGMs post-operatively, whereas this severe category did not do well. The AGM reduction was only down by 0.25. We did have complications, however, most of them were managed conservatively. There were transient hyphemas seen, there were steroid responders, there was transient IOP spike, and also cases of peripheral anterior synechia at the end of 3 months. We do have study limitations from the perspective that it's a retrospective chart review, so no control groups wherein phaco alone was done was taken into consideration. There is no standardized follow-up. We did not stratify it over months. We directly checked the IOP at the end of 3 months for the study. Also, the fact that this was a small sample size and we need longer term follow-up to actually extrapolate these results to our clinical practice. But in conclusion, I would say that there is a significant reduction in IOP and number of medications across all severity of glaucoma. It is a cost-effective and accessible method, accessible to every institution, and also it may delay a more invasive procedure for severe glaucoma. And when a patient is anyway undergoing cataract surgery, involving a bank procedure along with it will probably be a viable first step instead of a more conventional and aggressive surgical intervention for glaucoma. Thank you.
Last point was cataract extraction plus bank, right?
Yes.
It was not bar bank.
It was plus bank.
Okay.
Yeah.
I just wanted to know.
Then, so 90 to 120 degrees.
So is there any,
It was-
have you done gonioscopy after 6 months? This is 3 months follow-up only?
This was 3 months follow-up
Okay,
only.
so any scarring or anything?
PAS
gonio?
was there, ma'am. There is PAS. Of course, like now, this study concluded about a few months back. So
Yeah.
now I have few patients who are following up longer than that. So yes, there has been a lot of also fact that, you know, there is pigment dispersion. I even found a patient that had iris pigment dispersion in the anterior hyaloid phase in an uncomplicated surgery. It probably goes through the
So we
zonules.
really don't know the
And
long-term
yes,
outcomes
follow-ups.
of the
Yes,
procedure.
yes.
And the other question is that you said in severe glaucomas the efficacy was less of this procedure. So severe glaucoma in terms of IOP, did you find any difference? Because studies have shown that if the IOP is high, then the reduction of pressure is also
Right.
better.
Right.
Even
So,
if
ma'am,
it's an
this is-
advanced glaucoma.
Yeah.
So in terms of IOP, like what was the difference? Higher IOP, and because in normal tension glaucoma, the reduction of IOP will be less.
Correct.
Okay,
Correct.
so-
So this is a point that I can't really overemphasize, that the categorization of patients into mild, moderate, and glaucoma was only based on the visual fields.
Okay.
So that's how we categorized it. And yes, you're absolutely right that the number of medications and the IOP drop with patients who have higher IOP is much better.
Much better.
That's why we found that the NTG cohort of patients were less benefited with this procedure compared to the higher POAG spectrums.
Okay, thank